Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a totally unedited recording of phacoemulsification under topical anesthesia of this soft cataract. This is the main incision with a 2.8 mm keratome at around 11:30 o'clock. You can see oozing of blood from the lips of the wound. Visco is injected to fill up the anterior chamber and it is applied over the ocular surface for better visibility. This is a side port on the left side of the main incision, about 2.5 clock hours away. And now capsulorhexis with this instrument. This is a Utrata forceps. The capsular tag is raised and the capsular tag is guided anti-clockwise all around to do this rhexis. Yes, it is done. And now hydrodissection. BSS is passed just under the anterior capsular rim and the nucleus is rotated. Again some visco, and now nucleus management. The tip of the phaco needle goes in, bevel down. Some superficial cortical lens matter is removed. The nucleus is rotated clockwise as well as anti-clockwise, and now direct chop. The tip is buried into the substance of the nucleus and the nucleus is chopped. I thought it is a soft cataract, but it is not so soft. Nucleus sclerosis is about grade 3 or even grade 3 plus. The nucleus is divided into pieces and the pieces are emulsified and aspirated. Ultrasonic energy is 70%, flow rate is 45 ml per minute, vacuum is 450 mm of mercury. And now this is the last piece and then the epinucleus. At this time I use the Phaco 3 mode where the vacuum is 250 and flow rate is 25. And now some cortex is there. I'm going to use a 23G Simcoe cannula to remove the cortex. Cortex is removed, a bit of cortex is there, subincisionally it is also removed, and now the posterior capsule is polished. And now in this case I'm going to use this cartridge. This is from Appasamy and the intraocular lens is Naspro. No financial interest. The lens has been folded in the cartridge, and now this cartridge is difficult to engage to 2.8 mm wound. So I'm going to enlarge the wound a bit, just one cut. It is about 3 mm in size now, and here it is. The lens goes in and the lens has gone in the bag. And now the visco is nicely removed. All the visco from the antechamber, from the capsular bag removed. The lens is nicely centered. This is a bit of moxifloxacin. The side port is closed by hydrating corneal stroma on either side of this wound. And now this is the final lavage of the anterior chamber. We can do surgery fast, but it is more important to be meticulous and safe than to be swift. The integrity of all the wounds are checked, few drops of moxie is applied, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence.